Great, great. I think we can stop the video there. I think the
The
suturing portion
oil
of it we don't have
transfer.
to show actually. Hi, everybody. Thank you for your patience. I'm sorry I'm a little bit delayed, but I hope that some of the videos have been helpful. So you've already watched the Kotaro as well as the Bionico videos. Is that correct?
Yeah.
Okay, fantastic. So um, I'm so delighted to see all of you. I'm hoping, John, you just made the introduction to these two sets. Is that correct?
Correct. We just went over Kitaro and then Bionico. We mostly played your videos, but yeah, that's what we have done so far, Lisa.
Fantastic, fantastic. So if it's okay with you, I'm going to give just a brief talk about capsulorhexis. Capsulorhexis is a technique of capsulorhexis. So the what we call CCC, the continuous curvilinear capsulorhexis. John, is that appropriate at this moment?
Yes.
Okay, fantastic. Okay, hang on one second. Let me see if I can share my screen here. Okay, hang on. Okay, yeah. Something a little bit, somehow Zoom has changed here, and I'm having some difficulty sharing this presentation. Let's take a look. Hold on. Documents, Liquid. Oh, here it is. Okay. Are you able to see the slides? Okay, fantastic. Okay, so this is essentially some of the details of mastering this portion of the surgery, which is different from doing manual extraction. In manual extraction, I understand that most of you are opening the capsule using a can opener technique. Would that be correct? Is that what most people are doing at this time?
Yes.
Okay, so the can
Yes.
opener technique, a discontinuous. So you're puncturing and then making multiple punctures in the capsule in order to get access to the lens. Is that an appropriate summary of what's happening right now for most of you?
Yes.
Okay, very good. Okay, so now
Yes.
we're going to talk about the reasons that using a curvilinear capsulorhexis is necessary in order to do phacoemulsification is simply that the radial forces when we're doing phacoemulsification can tear out a discontinuous capsulorhexis, and therefore, in order to do phaco, you need to master this portion first. Can I ask of all of you, how many of you already have performed continuous or CCC or continuous capsulorhexis? Anybody here?
Yes. I've done few.
Okay, okay. Anybody else?
I didn't
Okay.
get.
Yes, me too. Me too.
Done few.
Okay, so everyone's done a few, so you understand the basic concepts of it. So I'm just going to talk a little bit about some of the pearls and things, some of the techniques and instruments that we use in order to try to get this to be something that's regularly and easily performed. Hang on one second. Here we go. Okay. So the secret to capsule arrest is this practice, practice, practice. That's why we're doing these dry and wet lab sessions. And so you can see here that this is the lens capsule. We know that it's comprised of type 4 collagen, and you can see the thickness of this tissue is very thin overall, but it's thinnest at its posterior pole. So we're talking in terms of microns, how thick the capsule is, and you can see here that it's thickest at the equator. But we're obviously going to make an opening in the anterior portion of this capsule. We know that the lens capsule is connected to the ciliary body by these very, very thin zonules, the zonules of Zinn, and that the attachment is, from the equator to the ciliary body. These are fine, tissues that we have to try to keep in place in order to maintain a capsule for the lens, for the intraocular lens. And our objective is here to make a continuous curvilinear capsulorhexis to resist radial tears, to stabilize the nucleus, and to center the intraocular implant. And so that is the point of doing this. Okay. Here are some of the tools that we use. So we usually make a puncture using the traditional instruments that I'm sure that you are using, and that is basically the bent end of a 27 gauge needle. You can also get these pre-bent, but if you don't have one, then you can just bend a 27 gauge needle. And then generally we're trying to grasp the fold or the edge of that the tissues using a capsulorhexis forceps. They come in different versions and types. They have usually a flat platform at the end. Some of them are what we call utratas. Some of them are cross-action forceps. And these are the instruments that we're generally using to perform this maneuver. And if you don't have these instruments, we can continue to do this with the needle. And that is actually my preferred technique.
Use needle capsulosis, but I'm just going to say needle as well as to bring. Just go with it.
I'm sorry, I couldn't hear. Did you? Is it Dr. Dedeje? Okay, so maybe we'll. Okay, so we're going to proceed. So the most important thing here actually is. Okay, hold on 1 second. If we go back. One of the most important things is visualization. The ability to do this requires us to see very carefully, and so head positioning and is very important in order for us to see very well. And so you need to have the iris plane parallel to the floor. And so oftentimes we're putting patients on a bed with a something to support their head, and it may be that positioning is not correct. If the position is not where their iris is flat to the floor, you're going to get incorrect visualization that will not allow you to do this very well. And so it's very important to do whatever we need to do to get that to be flat. In our case, oftentimes we're moving the bed, but if you have no ability to move the bed, then we're going to have to maybe, put pillows underneath, things to support the rest of the head or neck. So you can see here, in a person who has a lot of scoliosis or kyphosis, if they lie down, you're going to put a lot of pillows underneath, and the head is actually, and the iris plane is not going to be flat. And so therefore we do things to try to make them flat. And the reason why is our visualization requires good coaxial illumination. I've actually recently been doing some research on the various types of microscopes. And so the development of the OPMI microscope is very important because it gives you coaxial illumination along with lateral illumination. When we see this diagram here, it would appear that the lateral illumination is actually very oblique. But the answer is it's actually not that oblique at all. We're talking about a 2 to 6 degree movement of the illumination in order to get the coaxial versus the lateral or oblique lighting on the eye. And so it's important to understand that for us to get that good red reflex and to be able to do this capsulorhexis, the coaxial illumination is important, and the flattening of the iris plane is very important. Other tools that we can use in order to gain visualization is to stain the anterior capsule. We're often doing this with dye if that's available. We're using trypan blue dye straight, but we know that if we dilute this, if you have one vial, you can actually use this and extend this for many, many cases. And the amount that is needed is very small, probably even just 0.1 cc's. And so the longer you put this on the capsule, the longer, the better it'll stain. So what we do is we fill the eye, we let it sit for 30 seconds, and then we rinse out. You can use other dyes like indocyanine green, and this is what we actually initially used, but those are a little bit more expensive and difficult to obtain. And then we like to flatten the capsule with viscoelastics. I will also talk a little bit about different types of viscoelastics that we use. And so this is important to not just maintain the space, but to flatten the capsule to allow us to pull against it in order to achieve this capsulorhexis. So here it is. You can see here, these are different types of viscoelastics. I know that you guys call it maybe just visco, but the classification of these two types of viscoelastics into cohesive and dispersives is important. The dispersives we're using mostly to protect our endothelium. The cohesives we're using to maintain space and to flatten that capsule during this part of the procedure. And so we can see that here. So this is a dispersive viscoelastic that I'm putting in first in order to protect the endothelium. And then I like to use an arsenal shell and put a cohesive underneath to flatten the capsule. So that's my technique of choice simply because of the way I'm going to go ahead and pull the rhexis around. And the first step is you want to do this capsular puncture and then make a linear cut in order to pull a flap around. So we like to puncture in the center and then flap it over. And you can't push the needle too hard. If you push it too deep into that cortex, you're going to stir up the cortex and obscure your view. And then step 2 is to make this flap. And so you puncture, pull to the side, and pull a flap over in order to make this go around. And the creation of the flap is very important in order to have an area to grab in order to make this opening. When we talk about grabbing the flap, we like to grab not exactly at the fold or the area that is directly next to the opening. We like to grab a little bit, about a millimeter or so ahead of the flap, and that allows us to then bring that around grasp it and bring it around very easily. When you grab the flap and you bring it around, we also like to reposit it in the center in order to have an edge that's easier to grab onto for the next part of the portion of this. And so these are important steps that we like to do. So keep the capsule flapped over. That is very important. And then we like to tear tangentially. So the tendency is if the flap starts to go out, that your general reaction is to try to pull to the center to try to bring it back. If you do so, the flap is actually going to tear further out. And so what we recommend is pulling in a tangential around the curve of the circle in order to get that to go around. And here is a video showing that here. So this is insertion of the dye. We're going to go ahead and rinse that out after some seconds with some VSS. And then we're going to inject some viscoelastic to flatten the capsule. This is creation of the main bone. And then you can see her puncture of the center coming to the side to make a little flap come over, making sure that the flap is actually all the way over so that you have something to grab. And then in this is actually my preferred technique, and that is to continue to use the assisted tone. And as you can see here, where is the cystotome engaging? It's engaging about a millimeter or so ahead of the fold in order to move that all the way around. And you can see that the motion is in the direction of the circle, a tangent. We're not bringing that to the center. We have to make sure that the flap is going all the way around. And I'm actually teaching one of the residents, I guess, and I'm saying you have to go around and around. And so we want to stay ahead. You see how the flap is actually very nicely flapped over the leading edge here. And so if you keep that, you can actually follow then the edge of that circle in order to make this go really round. And now we're going to try to bring that again, the tissue back to the center in order to make sure we can see and meet the edge of that capsular edge. We should understand that the quality and the sensation of the capsule will vary in different conditions. And so a young patient versus an old patient, it will be very, very different. In general, the younger patients have a very rubbery capsule. The old patients can have very fragile capsules that can break apart very easily. If you have a soft versus a dense cataract, you'll also have a very different sensation as you puncture with the needle and try to move that to the side. And one of the most difficult scenarios are when you have a Morgagnian cataract with uncontrolled diabetes and you have a lot of liquefied cortex behind the capsule. When you puncture, you have to be careful in those scenarios. And the problem in those scenarios is you can get this, what we call the Argentinian flag sign. We call it Argentinian flag because it breaks apart in the center. But I would dare to say it's very similar to this flag here. So I'm going to show this next case, and this is a young girl. She's 16 years old, and she came to me with a diagnosis of type 1 diabetes, uncontrolled. She went from somebody who could see to somebody who couldn't see within months. And she had light perception vision when she came to me. And so you can see it's a complete white cataract. We know that there's liquefied cortex behind. This is from the osmotic changes from her diabetes. And so we made a small puncture, and I'm actually sticking a 27 gauge needle into that opening in order to try to aspirate some of that liquefied cortex. And then I'm injecting a very heavy, dense viscoelastic in order to try to tampen on that because I know that there's going to be some posterior pressure. And so I'm gently trying to open this, and you can see here that I made the flap. The flap is coming around, but I'm immediately getting the sensation that this is not going to follow what I wanted to do because of the tension from the liquid. So I'm actually going to come around from the other side to try to create another opening. But I can sense here that it's actually going to be very difficult. So now I'm going to puncture in another portion just to make a small opening. Otherwise, this is going to tear all the way around. So just an opening in order to see, and you can see now it's split open. So this is the pressure from Argentinian flag. However, we're going to proceed still with phago in this case. Our concern is that a radial tear can go all the way around. And so I've decompressed a little bit more and tried to make this, again, a little bit more curvilinear so I don't get continuous radial tears. Because it's such a soft nucleus, we're able to get this out with almost no emulsification needed. So it's just some gentle irrigation and aspiration and removing a little bit of the cortical material. So we're very fortunate because the area of defect is not wrapped around to the posterior capsule. And so in this scenario, we're actually able to put a one-piece lens into the bag. So at each step, I advise that you make adjustments. Some of the things that we also try to do is we try to make this opening smaller than the opening of the optic of the intraocular implant. So if your intraocular implant has an optic of 6 millimeters, we're trying to make 5 to 5.5 millimeter opening. You can consider using calipers to try to gauge exactly how large that opening should be. And I'm going to show you that right here. So this is one of the things that we sometimes use, especially in teaching, and that is a guide that we can put. This is a plastic ring that we're going to put directly onto the lens itself. We're going to pat it down. This is onto an intact anterior capsule. And then we're going to make the puncture and use the edges of that plastic area as a guide for us to see to make sure that we get a 5.5 millimeter opening. So you can see just pulling against that capsule had already been stained with and blue dye, so you see the blue tinge. You can see the very nice coaxial illumination from the microscope, and using this, we can get then a very nice circular opening, which is then removed gently from the eye. There are other instruments that can do this. There is the Zepto, which is basically can actually burn the opening of that size. But these are some of the tools that you can use. And then it's very important that this is the maneuver that we use when we believe that the capsule axis is actually going to radialize and go out to the periphery. So you can see here that again, this capsule has been stained. We're using a neutronic forceps to try to bring this around. And as we're coming to the last quarter, you can see here that we're approaching the edge. And the mistake that's being made here is that the natural tendency is to try to pull to the center, but you can see the flap is not flapped completely over, and therefore it's going more and more into the periphery. And soon it's going to be under that iris edge, and you're not going to be able to see it. And so the little maneuver is a technique that was described by Brian Little, where basically we're going to actually tear in the direction, and we're going to put a little viscoelastic to flatten that capsule back, to put it back where it was. And so you see the flap is flapped over. We're going to return it to its original location. And we're going to give a gentle pressure or gentle tug in order to bring that towards the center. So again, it's in the direction where we're tearing these two pieces apart just gently in order to bring that to the center. And we're able to then complete the rest in this particular case. Okay. Let's see that again in another form and here. So you can see here again that the opening is now going to the periphery around in here, the 2 o'clock position, but we've now flapped it back. We're flapping it back rather than keeping it flapped over. We're going to, rather than continuing in the same manner, we're going to try to just separate those two
Lisa, we
edges.
cannot hear you very well. I think there is hoarseness in the voice. Sorry.
Okay. Can you hear me now?
It's not clear.
Okay. Can you hear me now or no?
Yes, now, yes.
Okay. Okay, so you can see here this little maneuver. We're essentially going to flap this back. And we're going to pull in the same direction in order to just make a slight tear towards us. The reason why you cannot do this continuously is because it's slightly uncontrolled. And so therefore, we're going to do just for a portion, and then we're going to do a complete flattening and flap over, and then continue the capsule axis as we normally do. So this is called a little maneuver to try to bring this back towards the center just for a few millimeters before we go ahead and again flap it over in order to complete the.
We still cannot hear clearly. I think there is issues with internet connection, maybe. Unless my colleagues can hear clearly.
Let's see.
Same here, there are some echoes.
Okay. Are you able to hear me now? Okay.
Now it's
All
better.
right. That's the end. That's the end of this portion. Okay, so I apologize. What I will do is I will also make this PowerPoint available to you. It's a little bit, we're trying to overcome some of the challenges of sending such a large PowerPoint to you because we know this takes up a lot of memory and a lot of, storage or whatever it is. But we will do our best to do that for you. Does anybody else have any questions? Okay. So what we will do,
Just
I
one
think
question.
Amy's going to give some
Larissa.
further instructions about What we would like you to do is when you go through the next phase, you are going to be practicing on the dry lab kits and wet lab kits, and we would like to see your videos so that we can comment on them. What we ask you to do is we ask you to record on your phones. We have given, and I don't know if everybody will have this, but a connector to the microscope in order to put your cell phone and make a recording of what you're doing. If you can choose your top 3 videos and upload them as instructed, and then we will review them and give you feedback at the next meeting. That's it for me. Amy, do you have any other announcements?
Yeah, I had already shared that we will be providing the instructions on how you can upload onto YouTube. And please know that our next webinar will be Monday, July 21st. So please save that date. And did someone have a question? I thought someone had a question.
Someone had a question, yeah.
Okay.
Maybe from Tanzania?
Yeah, I was just asking, is it necessary to put an air bubble before putting the tryptophan blue, the dye?
No, it is not necessary. Some people do that. They do that to tamponade the trypan blue dye onto the capsule. But actually, I never use an air bubble. So yeah, if you use a small amount, especially if it's dilute, you don't need the air bubble. What you want to be careful about is you don't want to inject that obviously anywhere into the stroma of the cornea. And so, yeah, but has no, and if you do, and I've seen it happen, inject it into the cornea, obviously then you're going to get an obstructed view. That is actually temporary. So you have to abort your surgery, allow that patient to wait a day, and then come back to the OR. That will clear up within a day. So you can't do it you can't do the surgery at that same time, but it's not a permanent problem.
Thank you.
Some people also put the trypan blue dye in, and then they'll actually use the viscoat to remove it. And some people also will use the instrument to spread the dye across the anterior surface of the lens. I feel that if you give an injection of the dye across the entire, and you saw I filled the entire anterior chamber and then wash it out with a bounce salt solution, that is actually adequate in order to stain your capsule. Any other questions? Okay. Thank you so much. I really appreciate it. I apologize for being delayed, but I was happy that I was able to meet with you today.
Thank
Okay.
you.
Thank you.
Okay,
All right.
thank you.
Thank you.
Thank you. Good night.
Good night.
Thank you.